So let me just check whether my screening is live or not, and then I'll be talking about it. Okay, so good to have you with us. Welcome to the class, guys. Let me just see if the streaming is live, so that, yeah. So just give me a thumbs up if you can listen to me and hear me properly. Just give me a thumbs up, guys. Hi, welcome to the class. So today we are here to talk about a live discussion session on the surgery MCQs. Okay, so hello, hi friends. Okay, fair enough. So good to have you. I think we are live, and let us move on and let's talk about this particular thing. So I'll just wait for a couple of students to join us. By that time, if you have any doubt, if you wish to ask me anything, you feel free. You can definitely ask me this particular thing. So okay, now let's begin. Let us begin with today's session, as around 8 of you have already been online. So let us begin. Right. So YouTube live session on the surgery MCQs. Let us begin. So what is the treatment of this particular condition? So what you're seeing in here, this is basically a patient who has underwent a upper GI endoscopy. So what is here? Here you have upper GI endoscopy image. And now what I'm asking basically, what is the treatment of this particular patient? So what do you think is the answer, guys? So hi, welcome. Yeah. What is the answer? Just write in the comment box and tell me what is the answer to this particular question. Okay, so Bala is saying it's D. Okay, and Matt for AIIMS is saying B. Aditya is saying it's D. Okay, right. So Bala, why do you think it's D? What will you resect and what will you anastomose? So this is basically an upper GI endoscopy, and what you're actually seeing in here, this is an esophagus. Okay, so this is an esophagus. Okay, so guys, so I'll talk about the answer to this particular question. Can you please tell me what is the diagnosis? So what is the diagnosis? What do you think is the diagnosis in this particular patient? Okay, so what is the diagnosis? Yes, it is a ring. It is an esophageal ring. Okay, so what is present in this particular patient? You have a esophageal ring which is present. And yes, the answer to this particular question is in fact dilation. So yes, it is a esophageal ring, Schottky's ring, and the answer is dilation. Fair enough. Now, why will you not go for the resection? Why resection is not advisable? Because if you go for a resection, these patients may have a stricture and stenosis. So stricture and stenosis may develop in this particular patient, which you don't want. Okay, if you do the resection, the patients may land up into the stricture and stenosis. Now, what about this? If at all, they can ask you this also. So what is this? This is a barium swallow. So this is a barium swallow image of a patient with an esophageal ring. Okay, so this is a barium swallow image of a patient with an esophageal ring. Now let us talk about the esophageal ring. How many types of esophageal rings are there? So we have a type A esophageal ring, we have a type B esophageal ring, and we have type C esophageal ring. Now this type B is also referred to as, some of you which have already told me, this is a Schwarzschi's ring. Okay, so this is Schwarzschi ring. Okay, but what about this A? This is the one which is present proximal to the to the esophagogastric junction. Okay, or maybe a proximal to the squamo-columnar junction. Squamo-columnar junction. And this Schwarzschi's ring, this is present at the squamo-columnar junction. Okay, so at squamo-columnar junction, we have a Schwarzschi's ring, and the C ring, this is present actually distal or beyond the squamo-columnar junction. Okay, so this is present beyond the squamo-columnar junction. So this is something which you need to understand by the ring. This is a barium swallow. This is an upper GI endoscopy finding. And if at all you find a kind of a ring, esophageal ring, you have to go for a excision. You have to go for a dilation. Okay, so you have to go for a dilation. You cannot go for an excision or a resection of that particular ring, because these patients may land up with stricture or stenosis. Understood? Now let's move on to the next particular question. So the next question which we wish to talk about is, which of the following statements about diffuse type of the gastric carcinoma is true? So which of the following statements about the diffuse gastric carcinoma is true? Can you please tell me what is the answer to this particular question? Right, so which of the following statements about diffuse gastric carcinoma is true? Anybody? What's the answer, guys? What is the answer? Yeah, what is the answer to this particular question? So you guys are saying it's B, C, whatever. Okay, so C is the most common answer which I'm getting. Then we have got B and D. Okay, fair enough. Right. So guys, good, very good. So right. So guys, the correct answer is in fact the most common site is the fundus. Okay, so this is the correct answer. Yeah. So let us talk about this. Now this question was based on something which is called as a Lorentz classification. Now this is something very, very important. So this is based on Lorentz classification. Now this is very, very important. What is this? This is basically a pathological classification of gastric carcinoma. So what is this? This is a pathological classification. Okay, now let us talk about this. This is very, very important. So according to the Lorentz classification, how do we divide the gastric carcinoma? They can be divided either into an intestinal type. Okay, so they can be divided into an intestinal type, or they can be divided into a diffuse type. Okay, so now many students have faced problem in this particular classification. That is why I've decided to cover this. So this intestinal type, let us talk about this. So whenever you have this intestinal type of a gastric carcinoma, so this is basically for a gastric carcinoma. Okay, so please understand, this is for a gastric carcinoma. So whenever you have an intestinal type of a gastric carcinoma and you want to remember the features about this, just close your eyes and try to think about a prototype patient of a gastric carcinoma. So if at all you have an ideal patient of a gastric carcinoma, what will be the features in him? He will be a male. Okay, so classical gastric carcinoma, it is more common in males, it is more common in elderly. Do you see a gastric carcinoma in 30-40 years? No, right? You usually see it in elderly patients, close to 50-60 years. Now, another important thing which you need to understand with the intestinal type is, first, it is more common in the males, it is more common in the elderly. Then what else? What is the risk factor for a intestinal type? It is an environmental risk factor. Okay, environmental. So what do you understand by an environmental? That is H. pylori. Here what I am talking about is an H. pylori. Okay, and then lastly, what is the most common site of an intestinal type? So the most common type most common site in the stomach of the intestinal type of gastric carcinoma, it is the antrum. Okay, so as I have told you, the way to remember it, if you just close your eyes and if you try to recollect what is basically a ideal patient or a classical patient of a gastric carcinoma, you will find all these features. Now once you have come to all these features, exactly the opposite fit with the diffuse type. So in the diffuse type, it is more common in the females as compared to the males. It is more common in the young people. Okay, then what else? It has a hereditary risk factors. Okay, so it has a hereditary risk factor, and the most common site in the stomach, it is the fundus. Okay, so if you just go back to the question here, it is not more common in elderly, it is more common in the young people, it is not more common in the men, it is more common in the females as compared to the male. The diffuse type I'm talking about. And the most common site is in fact a fundus. Fair enough. Now, let us talk about the other features about intestinal and diffuse. What else you need to understand is, there is something which is called as a signet ring cell. Okay, so signet ring cell, if I just ask you overall, signet ring cells are seen in, and if I just ask you, and if you have not read this kind of a Lorentz classification, what will you tend to answer? You will tend to answer that it is seen in an intestinal type, because signet ring, in our mind, we correlate it with a clear cell kind of picture, and we logically arrive at an answer that is an intestinal. But please understand, signet ring cells are a feature of a diffuse type. Diffuse, okay? Please understand. Okay, so diffuse type. Now the another difference between the intestinal type and the diffuse type is that in the diffuse type, what is a mutation which we have? We have a E-cadherin mutation. This is also very, very important. So familial gastric carcinoma or a diffuse type gastric carcinoma, we have a E-cadherin mutation. And in the kind of a intestinal type, okay, so intestinal type, what do we have? We have a FAP syndrome. It is associated with the FAP syndrome. So yes, that will have a APC gene mutation. Are you understanding my point? So these are the features which you need to understand. That is basically the crux of the Lorentz classification, and this is something which you need to understand between the intestinal type and the diffuse type of a gastric carcinoma. Fair enough? Let's move on. So this is about the question number 2. Let's move on to this particular question. This complication is most common on which post-operative day? So here, what we are seeing over here is, this is a kind of complication which has occurred in a patient after a surgery. So this kind of complication, it is most common on which post-operative day? right? So is it 3, 4 to 5, 5 to 7, or 9 to 10? What do you think is the answer, guys? So Dhananjay is saying it's D. Most of you are saying it's C. Okay, so diagnosis is burst abdomen. Good, fair enough. So yeah, most of you are answering at C, and yes, absolutely correct. You all are correct, guys. The answer is, in fact, it is 5 to 7 days. So depending on what exactly is given in the option, you have to either choose 5 to 7 or 6 to 8, whatever is given in the option. Okay, so yeah, fair enough. So the burst abdomen most probably occurs on the post-operative day, 5 to 7 or 6 to 8. Fair enough. Right. Now let us talk about what exactly happens in the burst abdomen. So what is burst abdomen actually? What is burst abdomen? So what is happening over here is, during the surgery, what you did was, during the surgery, you so first you give incision on the skin, then the subcutaneous tissue, then the muscles, and below the muscles, just before entering into the peritoneum, what do you have? You have a sheath of the abdomen. Sheath of the abdomen. Now once you have done with the surgery and you want to close the abdominal wall, you first take sutures on this particular sheath, because this is a very, very important. Okay, so first you close the sheath of the abdomen. Now if at all the sutures of the sheath of the abdomen, they give away in the post-operative or the peri-operative period, then the patient lands up into burst abdomen. So what exactly is happening in the burst abdomen? In simple words, if we basically talk about the sutures which you had taken on this sheath, on the sheath of the abdomen, they have given away. The sutures on the sheath have given away. Are you understanding my point? They have given away. So this is what happens in the patients of a burst abdomen. Fair enough. Now, what is the importance of this? Okay, so why is it happening? What is the cause of burst abdomen? So is it a patient's fault or is it a doctor's fault? So it is a combined fault. It is not entirely a patient's fault. It is not entirely a doctor's fault. So what can be the cause? So anything which basically, if it, let's say if the surgeon did not take the sutures properly, okay, so if there was a defective technique, that is one of the cause. Defective technique of suturing, this is fine. What is the other cause? So a patient can also be responsible for this. So in the patient, if at all there is anything which is basically increasing the intra-abdominal pressure, increasing intra-abdominal pressure. Okay, so what are the things which will increase the intra-abdominal pressure? Let's say the patient is pregnant. Let's say the patient has ascites. Let's say the patient has a chronic cough. Let's say the patient has a BPH and patient is straining every time the patient is going to pass the urine. So all these are the factors which may lead to the burst abdomen. Fair enough. Now this is very, very important. This has to occur in the perioperative period, before the skin and the subcutaneous tissue and the muscles all have healed up. If at all it occurs late, after 1 year, 2 years or something, this will lead to a kind of a incisional hernia. Please understand, the difference is, if at all it occurs late, the patient may land up into incisional hernia. Perioperative period, patients will land up into burst abdomen. Why? Because by this time the subcutaneous tissue, the muscles, that has also not healed yet. Okay, fair enough. Right, yes, infection can also be one of the causes, so there can be any other cause. Fair enough. Now what else is needed in this particular thing? So how will you diagnose it? So how do you diagnose this particular thing? So please understand, this is very, very important. The first sign which you get in a patient of a burst abdomen is Salmon sign. So what is this known as? It is called as a Salmon sign. So what is this Salmon sign? When you basically on post-operative day 5 to 7, you see a large amount of gush of kind of serosanguinous discharge. It is not a purulent discharge. So serosanguinous discharge is coming out from the wound. Now this is what is called as a Salmon sign, and it is kind of a diagnostic of a burst abdomen. Fair enough? Right. Now let us talk about how do you treat this particular patient. So if at all the patient is kind of stable and the bowels have not yet come out and there is a minor breach in the kind of a sheath, you can try a conservative management. But most of the times what happens, as it was evident in this particular figure, the intestines are popping out of the wound. So if at all, it is not the Bagota bag, okay, it's not always a Bagota bag. Let's talk about it, okay. So if at all the intestine is protruding out, okay, so if the intestine is protruding out, okay, so if at all that is the scenario, then what you will have to do, you will have to take the patient immediately to the surgery. You will have to open all the sutures, you will have to give an adequate wash, and after the surgery you can try to close the abdomen. Or if at all you are not able to close the abdomen, then one of the techniques which you can use is a Bagota bag. So please understand, Pallavi, not every patient is a candidate for a Bogota bag. Okay, so maybe the technique of the suturing was not proper in the earlier times, and now if at all you are able to approximate the abdominal wall without any kind of a tension in the wall, then you can go for a primary closure also. And earlier times what we used to take something which is called as a tension suture. Now what is this tension suture? Forget about it. It's not that much important. Okay, so I'll just explain it to you what exactly is a tension suture. So what you do so when you are basically normally suturing the abdomen, what you do, you basically take the sutures very close to this particular edges. Fair enough. Now in this tension suture, what you do basically, you take through and through suture from the abdominal wall. What do you mean through and through suture? You pass it from the skin, you take it out below the sheath, and you don't take it very much near to the edge, you take it a bit away from the edge. This is what is referred to as a tension suture. This was advised earlier, but over a period of time many studies have proven that tension sutures are not advised and they don't help in the patients of a burst abdomen. So nowadays we don't prefer to take up a tension suture. Okay, but yes, I mean, if at all the abdomen is getting approximated again, you can go for a primary closure. If at all it is not getting approximated, you can try a Bogota bag or any kind of temporary closure. Fair enough. Now, true about the papillary carcinoma of thyroid is, which of the following statement is true about a papillary carcinoma of thyroid? Is it an undifferentiated carcinoma, blood-borne metastasis is commoner, excellent prognosis, or a capsulated? Very, very simple question, guys. Please answer. What is the answer to this particular question? What do you think is the answer, guys? So, right. So, no doubt, absolutely correct. It is a very, very simple question. Now, why did I put it up there? So, I put it up to make up a point. Please understand. So, no doubt, it is the one which is having the excellent prognosis. Very, very simple. Fair enough. Answer is correct. But what happens if at all this wouldn't have been one of the options and other thing would have been an option? For example, it is again a kind of a mindset. Okay. So, what we feel is, every time we feel that patient is having a good prognosis. Okay, so if at all a kind of any particular thing is having a good prognosis, so if at all you just apply your logic, and if I ask you if at all anybody has a good prognosis, should it be multifocal or unifocal? It should be unifocal. But what about the papillary carcinoma of thyroid? It is multifocal. What about if at all anybody has a good prognosis, should it be capsulated or non-capsulated? It should be capsulated. But what about the papillary carcinoma of thyroid? It is not capsulated. Now, if at all any particular tumor has a good prognosis, should it have a early lymphatic metastasis or it should not have any lymphatic metastasis? It should not have any lymphatic metastasis. But papillary carcinoma of thyroid is the one which has a early lymphatic metastasis, early lymph node mets. But despite all these things, it is the kind of a thyroid malignancy which is having the best or the excellent prognosis. Please understand thing. This is the point which I wanted to make it to you, because in the exam you might get a bit confused over this particular point, and that is the only thing which I wanted to stress. No doubt, I am sure all of you know that papillary carcinoma of thyroid is the one which is having an excellent prognosis. Fair enough? Right. So blood-borne metastasis is not common. What it happens is the lymph node metastasis happens, and it is not an undifferentiated carcinoma. It is the one which is a differentiated carcinoma, and it is not encapsulated. It is not capsulated. Fair enough. Moving on to the next question of the day. The use of tamoxifen for the breast cancer can cause all of the following adverse effects except. Now please answer this particular question. It is a bit tricky, but let's see if you can answer it. So what is the answer to this particular question? Which of the following is not a side effect of using tamoxifen for the breast cancer in the patients of breast cancer? So what do you think is the answer, guys? Right. So I've got my first answer. First response has come up as D. Then Aditya said it's B. Dhananjay is saying it's C. Right. So we are kind of battling between D, B and C. Okay. Right. So I'll just wait for a couple of seconds. The answer to this particular question, guys, is in fact derangement of a lipid profile. Please understand. Yes. The answer is C. Okay. Right. So let us talk about this. This is something which is important. Now tamoxifen basically stands for, it is basically comes under the category of SERM. Now all of you understand this, I'm sure about this. What is a SERM? It is a selective estrogen receptor modulator. Okay, so it is a selective estrogen receptor modulator. Fair enough. Now what do you understand by modulator? Modulator means that it doesn't have a same action on all the tissues. It has a positive or a good action on some tissues, and it has a negative or a bad action on some tissues. Okay, so now let us talk about tamoxifen. What are the tissues which are having a good action? So where does the tamoxifen has a good action on? So please understand, tamoxifen has a good action. Obviously, the first and foremost is the breast. Okay, so in the breast, tamoxifen is preventing the breast carcinoma to be occurring. Fair enough. Now, where else does this tamoxifen has a good action? So it has a good action on the lipid profile. Please understand. So here, what will happen? There will be no derangement of a lipid profile. There will be actually increase in the HDL, or the lipid profile will be absolutely normal. Okay, so the lipid profile. Okay, so it has a good action on the lipid profile. Fair enough. Now, at what are the places where this tamoxifen has a bad action, bad influence? Okay, so this tamoxifen is a bad influence for the uterus. So what happens in the uterus? There is a uterine hyperplasia, sometimes even uterine carcinoma. All these things can develop. What else? It has an adverse effect on the okay, so another place where it has a good effect is the bones. Okay, so please understand, even on the bones, the tamoxifen has a good effect, right? So where does it has a bad effect? On the uterus. Fair enough. On the blood, on the coagulation factor. So these patients can land up into DVT, increased risk of DVT, very, very important. And another is the ocular toxicity. So patients can land up into cataract. Okay, so it's a very, very well established side effect that is called as the ocular toxicity, which is occurring in these particular patients. Okay, right. So yeah, I mean, that is the point. Okay, so Ravi, what is happening over here is, in the, yeah, I mean, that is the side effect of this. Okay, so if you use tamoxifen, the patients are at the risk of undergoing a uterine hyperplasia and the uterine malignancy. That happens, Ravi. Okay, so that is a side effect. Please understand this. Okay, so I hope you got this. This is very, very important. This is something basically which you need to understand. Another very, very important thing which you need to understand is, when will you start the patients on hormonal therapy? So the hormonal therapy is started if at all the patients are ER/PR positive, ER positive or a PR positive. Okay, now if at all the patient is premenopausal, okay, menopausal, and if at all the patient is postmenopausal. Okay, fair enough. So if at all the patient is premenopausal, what is the preferred hormonal therapy which we give in these particular patients? Can you please tell me, guys? So yeah, Pooja, what is the preferred hormonal therapy which you give in the premenopausal women? Can you please tell me what is the preferred hormonal therapy which we give in these particular patients? So we give SERM. Okay, so what do we give? We get SERM in these particular patients. Okay, no, guys, in this whatever. So in this, what do we give? We give SERM, that is selective estrogen receptor modulator. But if at all the patient is postmenopausal, in these patients, what we go for? We go for an aromatase inhibitors. Okay, so in these patients, you go for aromatase inhibitors. Now this is a very, very basic concept, but you obviously need to understand this. Okay, so in postmenopausal women, we prefer to go for an aromatase inhibitor. In the premenopausal women, we prefer to go for SERM. Okay, so please understand this, very, very important. Okay, right. Okay, right. Now let's talk about this particular thing. So what do you think it is? A spot diagnosis, guys. What is it? Spot diagnosis. Fast. What is the diagnosis of this particular thing? What do you think it is? It is gamma camera. Seriously? Okay. Anything else? Spot diagnosis, guys. What is it? Chemo port. Absolutely correct. Very, very good. Ravi and Matt for AIIMS. Very good, guys. So what was that? That was a chemo port. Okay. So that was a chemo port. So this is what is a chemo port. Okay. So this is a chemo port which we have kind of taken out of a body of a patient. Okay, so this is a chemo port. Now you see this diaphragm. So what you do basically, with the help of a needle, you inject your chemotherapy into this particular thing, and via this tube the chemotherapy goes inside the central vein. So this tip is basically inside the internal jugular vein. So by this method, what happens, the chemotherapy directly goes inside the internal jugular vein. That is fine, but why did we come up with this chemo port? What was the need of introducing this chemo port? Why did we come up with this? There should be one or the other reason, right? So why did we come up with this chemo port? So please understand, in the patients of a breast malignancy or maybe any other malignancy, you have to give chemotherapy. So you have to give multiple cycles of chemotherapy. So in patients with breast carcinoma, usually we give around 6 cycles of chemotherapy. Now these 6 cycles of chemotherapy are spaced at an interval of 21 days. So what happens? There is a 21 days gap between the 2 cycles of chemotherapy. So what happens, every time the patient comes, you have to insert a IV cannula to the patient first of all. Now once the patient has received the chemotherapy, it is very difficult to insert the IV cannula. It is not impossible, but it's a bit difficult to insert the IV cannula. This is first point. Another point is, if at all due to any damn reason there is an extravasation, okay, so if at all there is an extravasation of the chemotherapeutic agent through these vessels, as you must have seen in the hospitals, many patients have an extravasation, or we call it as an IV cannula out ho gaya, IV cannula is out. So if at all that is a kind of a scenario which happens in this particular patient, what will happen? There will be a very, very bad side effect of it. So there will be a kind of dermal necrosis which might happen in these particular patients. So to prevent all these complications and to prevent this repeated insertion of IV cannula, which is kind of painful and not kind of that much okay with the patients, we came up with this chemo port. So once you insert this particular chemo port, it stays in the body for 3 to 6 months or 1 year, and after that you can remove this out. Okay, so there are certain chemo ports which can stay in the body even for 5 years. Okay, so please understand. So this is basically used to give a chemotherapy and to make the life of the patient a bit better, with less side effects. Okay, so this is all about the chemo port which I wish to talk about. Now what is this test which has been shown on this particular image? So what is this test? What test has been shown on this particular image and what for it is done? Can you please tell me what is the test which has been shown on this particular image? So Pallavi, Ravi, Matt for AIIMS, what is it? So Aditya is saying it is Azam. Okay, Shranya is saying it is HALS. Okay, so I think you were trying to say Halstead, is it? Okay, so AdSense, we say AdSense. So why do you do this? Like by doing this particular test, what is the diagnosis? Fair enough, very good Aditya. So this is basically an AdSense test which is being performed for thoracic outlet syndrome. So in the last game, what did they show you was they showed you a video image of Roos test. What did they show you? They show you basically a test of a thoracic outlet syndrome only. So what is this? Are you saying this? Basically the patient is looking at the other side and the examiner is kind of hyper extending the hand of the particular patient, and what is happening? He's kind of palpating the pulse. So if the pulse becomes feeble, this patient might be diagnosed as a thoracic outlet syndrome. Right. Now, what are the other tests which we can perform for these particular patients? So there is something which is called as a, what you guys are trying to tell me? Okay, so yeah, there is something which is called as a Wright's hyperabduction test. Okay, so there is a Wright's hyperabduction test. So in this, what you ask the patient to hyperabduct the arm above the ears. Okay, so this is something which is a Wright's hyperabduction test. You do the same thing. You try to palpate for the pulses. If it has become feeble, then it is a patient of a thoracic outlet syndrome. This is Wright's hyperabduction test. Okay, so it is a hyperabduction. Now what else you have? You have something which is called as a Roos test. Okay, so you have a Roos test. So this is also called as a East test. So what is this East test? This is an extended arm stress test. What you do, you ask the patient to go in this particular position, both the arms, and then to close and open the fist again and again. And over a period of time, because the blood supply to this particular arm increases, and so patient will develop fatigue and everything, and the pulses will also become feeble. Now another is basically the military position test. Okay, so there is a military position test, and this is basically what is called as a Halstead test. Okay, so please understand, guys. So this is what is called as a Halstead test. Nothing great. What you do, you ask the patient to go into the military position, and if at all the patient goes into the military position, that is the shoulders back, chest out, the patients can manifest this particular signs and symptoms of thoracic outlet syndrome. So these are the clinical tests which we do for thoracic outlet syndrome. Fair enough? Right. Now this is basically the end of today's session. I hope it was helpful to you. Thank you so much for joining with me, guys. It was indeed a pleasure to interact with all of you. If you're not, please follow me in Unacademy. It will be really great so that you can get notifications about whatever the classes, if at all, I conduct over a period of time. Another important thing is I just need a couple of minutes from you because I want to have a word with you. Okay, so I just want to talk to you about Unacademy, guys. So I hope our free sessions, whichever we conduct on the YouTube and also for on our special classes, I hope they are kind of being helpful to you. And if at all you want more help from us, you please consider joining the Plus platform. Now, why Plus platform? I'll just talk to you about in 1 minute. I'll just take up a question from Matt for AIIMS and then I'll come back to this particular slide. Please stay here. Just give me a couple of minutes, okay? Right. So Matt for AIIMS is trying to say, sir, can you take a class regarding the clinical science need for the AIIMS and give a list? We'll Google. Fair enough. Okay, clinical science you want a list. Okay, I'll try to do that. Matt for AIIMS, I'll definitely try to do that. On the Plus platform, I've already covered like a kind of a thing on the eponyms. I've covered a 2 hour session on the eponyms, but yeah, I'll try to do that, Matt for AIIMS. Yeah, surely I'll try to do that. Now coming back to this particular slide, guys, please understand. Again, I'm not trying to sell Unacademy for you. I'm not trying to sell that. But what I'm trying to do is, I'm just trying to tell you what exactly are we doing on the Plus platform. So I'm really hoping that whatever you're doing on the free platform, it is kind of beneficial for you. I'm really hoping that. Right. On the Plus platform for the AIIMS, if you just consider surgery, I've already covered my small course on the urology. I've covered my course on the hepatobiliary system. GIT will be ending in a couple of days. I've already covered all these courses, and the upcoming courses are the general surgery, vascular surgery, subspecialties. Okay, so all these courses will be coming for the upcoming AIIMS. For the AIIMS, we are also planning a MCQ marathon. So in this, I will be taking around 10 hours of the MCQ sessions on the Plus platform, continuous 10 hours of a MCQ session directed towards AIIMS and PGI. And every time the exams nears up, I always get up a question like, what are the most important topics for surgery? So this time what I decided that I will conduct a revision course in surgery. So what I'm going to do in here is, the course will be around 10 sessions, and in each session there will be 2 hours, and in this I will be covering close to 300 to 400 most important topics in general surgery. So this will be conducted in the month of April. So most probably the course will start around 12th or 13th of April, and you will be done with this particular course by 22nd, 23rd of April. Okay, so this is what I am doing for the general surgery, and each and every educator is trying to do the same on other subjects also. So I'm sure that if you just come on the Plus platform and you just follow through these courses, whatever you are weak in, whatever subject you are weak in, if you just follow the courses of that particular subject, that will definitely be beneficial for you. For the upcoming Neet PG 2021, I have already talked about this. We have launched our foundation course. In the foundation course, I'll be taking up surgery for 100 hours. So in the 100 hours, I'll be dealing with all the aspects of general surgery. And my style of teaching is the same. Like, I basically try to teach with the concepts, and I try to make you understand what is the reason behind these things. So entire general surgery will be taught to you in that particular fashion in the foundation course. Okay, so if at all you feel that this might benefit you, this might add up to your preparation, please consider joining the Plus platform. Okay, right, at this moment our courses, like the 1 year subscription, is being provided at 25k, and if you use a promo code, my promo code is dr.pawan. If you use that promo code, the kind of price will drop down to 22.5k. Okay, and yeah, if at all you want to take up a 6-month subscription, at present the cost is around 20k, and there will be a 10% discount. The price will drop down to 18k if you use a promo code. My promo code is basically drpawan-yt. This is your YouTube promo code. You can also use dr.pawan, whatever you like. The promo code will be in the description box if at all you wish to join it. Okay, so you do join it, you don't join it, that's completely fine. But I personally feel that if you are finding these 3 classes, whatever we are taking, beneficial, you will definitely love the classes which we take on the Plus platform also. They will be more structured, they will be much more detailed, and we will be more than happy to interact with you and connect with you on the Plus platform. So please do consider, just visit our page. The link to my page will also be in the description box. You can just go there, have a look at whatever the reviews the students have given us. You can see whatever the courses I have already launched, what I am launching. And if at all you join a subscription, you don't get access to only one educator. You get access to all the educators on the platform. You get access to all the test series, the upcoming Q bank, and the kind of a structured notes which we are already working on. So you will have access to entire platform of Neet PG in this particular cost. So please consider, if at all you feel that that might be beneficial for you, please go ahead. And if at all you decide to kind of join Unacademy, please consider using my promo code. My promo code is dr.pawan. You can use this, or you can also use a promo code that is drpawan/yt. So the the promo code will be in the description box. Okay, so you can consider using it. Thank you so much, guys, and yeah, it was indeed a pleasure interacting with you. Thank you so much for being here with us. Okay, thank you so much. Fair enough. Have a great day. Happy studying. Bye.